I think last but not the least, after the lecture of Professor Amir Ghafoor, it's really difficult. And prior to him, Dr. Khalid, one of the senior colleague of mine at JPMC, when I was just starting my post-graduation, he was there as the ultimate person who cleared in front of my eyes the FCPS2 way back in maybe 88, maybe 89, something like that. And he joined that place. And I left that place in 99, so he has already gone at that time. So he has a lot of experience with us at JPMC. So with that, I think we come to our topic. The topic of today's, my discussion is diabetes and depression. So this is entirely a different ball game, not the ball game that Professor Amir Ghafoor was actually defining. So it's the beauty of this session, starting from heart failure, then monkeypox, then clinical art, and then non-selective beta blockers, and finally come to diabetes and the depression. So it's really a beautiful session. And I indebted the PSIM for calling me in this session. I also pay thanks to the chairs and the overall organizing committee with sponsor of mine, the Lundbeck Pharma. The content of my presentation is, it will be showing impact and prevalence of both diabetes and depression, pathophysiology and correlation and implications of these two together, and then the core concept in current management of diabetes with depression. So we all know that what we are having in this part of the world where we actually reside, the MENA region, is showing a very high prevalence of diabetes, and unfortunately or fortunately, we have become the highest prevalent nation, not in terms of total number of cases, which actually still the China is the one, the second is India, but in terms of a new cases reported, we are having 31.4% prevalence of diabetes, and alarmingly, we have got the highest mortality with diabetes. So it is one of those things that people need to really take into consideration. Only area which is ahead of us is probably this area, the other area, which has got 84% and 156%. We have got the MENA region, 110. So these are the two other areas where people are also having the highest prevalence of diabetes. And unfortunately or fortunately, the low middle income people are actually the one who are the sufferers. And here we can say that 4 out of 5 individuals are from the low and middle income area. So we have to do something which is out of the box to take care of our patient. All those new things that is coming, we have to have those things at our patient to be delivered, but at a cost that they can take it for the rest of their life. Then if you talk about the top 4 countries, we can see that we have got the stable position both in 2021 and what we are going to see in 2045, despite of all that we are doing at the moment. आप लोगों के सबके जो पेशेंट्स हैं उनके ज़मीर को झंझोड़ने के बावजूद हम अल्टीमेटली क्या अचीव करेंगे? The same 3rd position in the world as far as total number of cases for diabetes in top 10. Now see what actually the similarity or dissimilarity that we got with depression in the same context. An estimated around just under 4%, according to WHO, just under 4% we are having total population having depression, and it is more in patients who are above 60. So we are going to see around 5.7%. It is more in women than men. And if you talk about the total number of cases, they estimated around 280 million people all across globe have depression, some degree of depression. 50% or more common in women, 10% pregnant ladies are depressed, 700,000 individuals, they die because of suicide, and the suicidal age, 15 to 29, under 30 years of age, and that is being contributed by depression. Similarly, 75% of the people are also from the lower middle income group, as we see diabetes. So these are the few similarity and dissimilarities. So if you talk about the prevalence in our part of the world, we can see that it's ranged between 4.5 to 5% in our region, but this is relatively an old publication. If you take recent, I think you may get more depressed individual in our nation, because overall depression is in the air. Then, if you talk about the correlation with the chronic illnesses, the NCDs, you can see that the NCDs has got, particularly with diabetes, you got the highest correlation of depression, and similarly so with the COPD and cancer and stroke. What are the things that actually impact diabetes may also impact the depression? And these include the lifestyle factors. And we can see that being overweight, more sedentary lifestyle, which is actually contributing to diabetes, smoking and alcohol abuse, poor adherence to treatment, substance abuse, sleep deprivation. हमारे यहाँ सुबह जो होती है वो 12-1 बजे होती है, रात जो होती है वो 1:30-2 बजे की जगह 4-4:30 बजे होती है. So these type of a thing contribute not only to NCDs, particularly diabetes, but they also contribute to our topic of today, that is depression. So these are few similarity. And same is true with hypertension and obesity, they're also contributing the depression. It's a bidirectional association. If you see the hazard ratio, depression going into type 2 diabetes, 1.1. And if you see the hazard ratio in term or relative risk, type 2 diabetes going into depression is 1.54, in fact. And you see from pre-diabetic status up to mortality, complications, all stages of diabetes has got an odds ratio in favor of depression. So you got a series of depressive series that it starts. So NCDs like diabetes has got other also domain to treat, not only controlling their dysglycemia, not only preventing complication, not only taking care of their physical activity, but also this particular part that people need to harbor. What is the correlation? Innate inflammation is a pathway for type 2 diabetes. And then what is the macrophage theory of depression? This is also being there. You can see the similar sort of words in green and red. So these are the similarities in pathophysiology. If you talk about depression associated with insulin resistance, you can see so many studies favoring, whether it is diagnostic interviews or self-reported, you can take that into account, favoring that depression lead to insulin resistance. If you talk about emotional stressor and physical stressor, ultimately ending up into central adiposity, insulin resistance, and heart-related findings, so you may get correlation, and that correlating point is adrenal cortex and adrenal medullary secretion, cortisol and catecholamines being the contributing factor for these insulin resistance that we achieve with emotional stressor and physical stressor precipitating as a trigger for depression. If you talk about mortality, particularly the suicidal intention being contributed, both major depressive disorder and diabetes, along with the other array of associated illnesses contribute into suicidal intentions and increased risk. If you talk about impact of depression on diabetic control, you can see that people who are being taken care of their depression, they behave well in terms of their dysglycemia, as compared to people who are having dysglycemia along with depression, and the control will be much more difficult in those cases. If you talk about cognitive behavioral formulation of psychological reaction to elevated blood glucose, this is the effect of diabetes on depression. Previously, we have studied in previous slide, the depression actually leading to dysglycemia and difficulty in control. Now, how the high sugar impact the depression more? You can see that the high reading of glucose gives, I have again failed, never get control of my diabetes. It leads to frustration, guilt, anger, and low mood, lead to behavioral changes to avoid other self-care activities for control of diabetes, and physical symptom of lethargy, osmotic symptom of hyperglycemia would be much more. So it has got a cascade. It affects the other affect the previous. This is how it runs, and that is a bi-directional correlation that we had. Then when to suspect in a non-psychiatric setting, how to suspect. Patient speaks with a monotonous tone, looks sad, sits with a slump posture, speaks abnormally slow, somatic complaints with no obvious cause. These are the few clues that you can take. and then the physical examination can make your diagnosis. As Dr. Khalid pointed out, that machine can take over, but they may not be able to take these things, and how much audio-visual contribution of managing patient can pick all this. Probably we need to teach our student much different, because we cannot reverse the cycle of the time. So we have to gear up as a teacher, not only just suggesting that what the golden era we had, but how we are going to do in next, we have to plan for that, being father and mother of the future generation. So I think that is my comment to Dr. Khalid, who is listening very carefully to my talk. Thank you. Using 2 screening questions, what are those? How you have been feeling, or what their mood has been in past couple of weeks, and number 2, how much the interest or a pleasure that he feel in couple of weeks. These are the 2 questions that can lead you to get something, whether these are present, and if present, you can do additional questioning. So when to indicate and formal psychiatric evaluation, these are the few clues, not complete clues, but few. Evidence of depressed mood, low body mass index, reluctance to start insulin therapy, persistent suboptimal glycemic control despite of every effort, every counseling, recurrent admission with ketoacidosis or severe hypoglycemia, difficulty at transition to an adult service advices. These are the few clues where you need a psychiatrist colleague of yours to help you out. Then there are certain studies which indicate locally as well that 60% of subjects with diabetes had anxiety and depression once they are talked in terms of diabetic control. Then another local study, one of our colleagues, Ashir Fawad, is also contributing, and BIDE, Bakai Institute of Diabetes and Endocrine, was the prime place where these studies have been actually done. The prevalence of depression is slightly higher in subjects diagnosed with depression, 13% versus 6%. If you talk about management paradigm, you got different questions which everybody asks for himself or herself, which treatment to start, when to follow, if not optimally having response, how to do it, switch, dose increase, augment, ensure compliance, how long continue the same treatment. So if you see the available antidepressants starting from 1950, 2000 and onwards, we can see there is quite a lot that people have gone and people have made new innovations to help people out with depression. So what is the right choice? The right choice, actually, you can see with the modern medications, one of the agents that has been recently introduced, although FDA has approved in around 12 years back, 2013, is vortioxetine. And what this particular salt is, that it has got the inhibitor of selective serotonin transporter, so the serotonin level in the synaptic cleft remains high. It is full agonist and partial agonist to 5-hydroxytryptamine 1A and 1B receptor, and it is being antagonist to 5-hydroxytryptamine 1D, 5-hydroxytryptamine 3, and 7 receptors. So single molecule having different effect on the 5-hydroxy pathway. So these are the few differences than the other that this molecule is having. So choosing an antidepressive agent, condition of the patient profile, sedation, whether the person is a driver, worker, or mother, side effect, contraindications, age, overdosage potential, dietary limitation, compliance, considering drug profile, efficacy of drug in treating the condition, both acute and long-term, efficacy in treating any comorbid, and then tolerability of drug and drug-drug interaction with safety profile of the drug. And last but not the least, the cost efficacy. So comorbid condition, something like cardiovascular disease with major depressive disorder, you need SSRI, SNRI, which with the better cardiac safety. Similarly, for patients who have got a hypertension and obesity, informed option for weight control and reduction, and certain antidepressive drug like TCS should be avoided because it has got the potential to increase weight. Then, if you talk about the patient's efficacy and acceptability, you find that SSRIs are the better one. And then if you talk about regional study, you can see that in this regional study, in diabetic population, it is the SSRI that has been taken as more important tool, although the agomelatine and bupropion also shows the potential in this particular group of people. If you talk about the complication of SSRI, they have got in 3-month use GI, weight, and sexual effect and insomnia. If you talk about sexual dysfunction, you can see that the vortioxetine, among the other, is very close to agomelatine, and it is something that you can take in this particular array of complications. Then if you talk about the vortioxetine benefit, it has got the damaged cell and phases benefit of different phases of sexual dysfunction. It is not contributing, but in fact benefiting the patient with depressed mood. And if you talk about the drug-drug interaction, you can see the different cytochrome enzyme system not showing much. And if you see that it has got no dose adjustment, renal, hepatic, and in patients with elderly population and cardiovascular dysfunction. With that, we can take the take-home messages, being alert to sign and symptom of depression with poor diabetic control, encourage people to seek treatment, use collaborative approach, educate and link between diabetic depression and hyperglycemia, decrease stigma of depression by linking the need to treatment, and with that, provide hope, particularly this part, the hope of explaining effective treatment that are now available. With that, I thank my audience.